Okay, so I just wanted to pick up, you know, obviously when you look at a capnograph or when you do end tidal CO2, which is called capnography, and you're assessing CO2 levels during inhalation and exhalation, and 35 to 45 is normal exhale that you need to know. Inhaled should only be 0 to 2. You need to know that as well. And then the other thing that you're assessing, well, it gives you a respiratory rate, but I always tell you listen or feel to get a respiratory rate. And then you also can look at the graph and look for abnormalities. So that's what this part talks about, what you might start to see. Like if the one thing I get concerned about is, say you had a good normal rectangle, like it was a normal height, you were getting a CO2 of like 45, 52, somewhere in that range, and then you get an abrupt drop in the rectangle. Well, that can be a drop in blood pressure or cardiac output, impending cardiac arrest, or impending like something with the cardiac system, because that's an indicator, unless it came disconnected but if you were getting like really good triangle or really good rectangles and really good tracing, and you get an abrupt drop instead of just like a gradual drop, you want to assess cardiac function, assess the blood pressure, feel a pulse, turn the patient down, because that can be a sensitive indicator also in a change um, in blood pressure. Okay, I'm skipping over acid-base status. The only thing I will say about PaO2, remember the difference between PaO2 and SpO2. And again, this is partial pressure, and A, to remind you, arterial. This has to be done with a blood gas. When you guys put the probe on the tongue, which is what you'll do the most often, that's an SpO2, which is an estimator of bound oxygen to hemoglobin. This is telling you what is dissolved oxygen. Now, again, when we do horses next term, we get into equine anesthesia, I'll talk about blood gases a little, because you'll do blood gas measurement is pretty routine when you're working with horses. It's done a lot more frequently. The other thing that you guys are monitoring will be body temperature, and this is checked sometimes. It's not always checked as frequently as the other vital signs you need to be checking every 5 minutes. This is not done. It is considered a vital sign. It is controlled by the hypothalamus. So that's the thermoregulation center. Now, normally if an animal becomes cold, if their temperature starts to drop, they should start to shiver. And that's going to generate body heat to bring up their temperature. The problem is, under anesthesia, they cannot shiver. The hypothalamus is, they're CNS depressed, so their ability to control their temperature is diminished during anesthesia. So again, when you're looking at temperature, it's really just an indication. We know we need a certain temperature to maintain normal body functions. Now, it can drop to a certain level, and different people have different comfort levels. Usually every 15 to 30 minutes. I used to have students, I'd hear they were in surgery and they'd induce the animal, and the first thing they would do is a temperature. And I don't know if that's because it's TPR. I'm like, maybe change it to PRT, because they're not going to drop immediately right after. I'm more concerned when you anesthetize an animal. Do they have a heart rate? Do they have a pulse? Are they breathing? Temperature, get yourself situated, and then you can put a thermometer in the rectum. And sometimes, like Dr. Ritz just has the students leave a thermometer in their rectum, like while they're in the prep room, and then you can just hit the button and periodically check a temperature. During surgery, the monitor in the OR has a temperature probe, and you guys can run it down the esophagus, and it'll run a constant, so you don't have to go under the table and try to take a rectal temperature. That monitor will give you a constant temperature during surgery. Now, the rectal thermometer is preferred, or you can use the probe on the monitor can be used esophageally or rectally. It's just we usually pass it in the esophagus. But the temperature probe, the ones we had at Purdue, we had these long plastic sleeves, and you can like cover it and put it in the rectum to help keep it clean. But if they were doing something to the head and neck area, you could always put it in the rectum. It is definitely going to decrease. And these are all the reasons, and I want you to be able to tell me multiple reasons. Why does the temperature drop during anesthesia and surgery? One I want you guys to know is temperature drops fastest in the first 20 minutes of anesthesia. If you can keep them warm pre-op, like have a heating pad, you know, and maybe rice socks, there's some other things you can do. If you can keep them warm in the prep room, you have a better chance of keeping them warm throughout surgery. But I will tell you, once they get cold, it is challenging to warm them up. It doesn't happen instantaneously. I've had lots of patients I've battled body temperature, but first of all, they're shaved, and then you scrub their skin, especially if you use, I'm not a fan of using alcohol as the rinsing agent. You guys in surgery will use a chlorohex scrub and a chlorhexidine rinse. Some clinics use chlorohex and then they use saline, because when you scrub the skin, it gets wet and the room is cold. So you take away fur, you wet their skin. Alcohol is a cooling agent. So I never, ever use alcohol on a pediatric patient. You can always use saline. The other thing I've done sometimes in pediatric patients, if I'm using saline, I'll warm it up. You can put a saline bottle get a dog bowl and run a bunch of hot water, and you can put your saline, some clinics have an incubator. And at BCA, we keep saline bottles for surgery patients in an incubator, and they're warmed to body temperature, so that when we use saline on the animal in surgery, it's warmed saline. Well, if you don't have an incubator, a poor man's incubator is a bowl of hot water, and you put your saline bottles in the hot water and you can warm them. So even if you don't have the fancy tools, I'm not a fan of microwaving stuff just because you can get hot spots and you have to be careful. So there's some techniques. They cannot shiver and use their muscles. So automatically temperature is going to drop because you're dropping their metabolic rate with anesthesia. And when you drop the metabolic rate, that affects their ability to increase. If an animal wants to increase their temperature, they increase their metabolic rate. You also, if you've got like a spay or an abdominal exploratory, their abdomen is open. They're going to lose heat. And the OR, I will tell you, an OR is typically the coldest room in your hospital for a couple of reasons. Number one, the scrubbed in people have gowns and masks and they can get hot. The other thing is that we don't want a room too warm because that increases bacterial growth. So ORs generally have to be cold. Now, if you open an abdomen, that cold air is going to chill the patient. Vasodilation, most of the drugs you'll use in anesthesia cause vasodilation. When you dilate a blood vessel, it loses heat. So vasodilation gives up heat. The ones you have to really be cautious of is the pediatric, geriatric. Now, geriatric patients tend to have a lower body mass. They lose muscle. Some are overweight, but some, if they're getting skinnier, they don't have as much insulation. So I'm really cautious of my pediatric and geriatric patients. The smaller they are, the faster they lose their heat. The fluids you use tend to be cooler. Now, the surgical fluids that we use at BCA are in the incubator. So when we hook a dog up to fluids, they are warmed fluids. Again, if you don't have an incubator, put the IV fluids in a bag of hot water. Now, one little tip, and not everybody knows about feeding babies, but if I have a baby bottle and I go to feed the baby, I drip the milk on the inner part of my wrist to make sure it's not too hot. If I warm fluids, I usually drip a little bit on my wrist before I hook them up. Somebody cranked an incubator at RVCA in the radiology department, and when I went to grab the bag to hook it up, it was literally hot in my hand, and I felt like I could have burned my wrist. and I took them off. Luckily, I didn't hook them up to the patient. And we checked the incubator, and somebody had turned it up, and they were way too hot. So again, you don't want them hot to the point that they would burn you. So I always, anytime I warm up fluids, if I do any warm food for feedings, if I do any like milk replacer or IV fluids, I always drip them on my wrist before I give them to the patient. So just a thing. Now, non-rebreathing systems, which are used, they're used on pediatric patients, or really patients under 15 pounds. They run a high oxygen flow, and oxygen is cold. So again, the higher your oxygen flow, the colder your patient is also going to be. So these are reasons that they lose body temperature. What are the complications that can happen? So there's definitely consequences to cold patients. They are, number one, going to take longer to recover. The colder they are, the longer they take to wake up. I want you to burn this statement into your brain. The colder they are, the less anesthesia they need. As temperature starts to drop in your patient, like sometimes I get patients that are just getting cold and I'm trying and I'm trying. You should be able to run less anesthetic to your patient. Does anybody know why? Why does a cold animal need less anesthesia, less gas anesthesia?
Because it doesn't let them regulate their body heat because they are asleep.
So kind of what's happening is, they lose that ability to regulate their temperature because their metabolic rate is lower. And if your metabolic rate is low, you shouldn't need as much anesthetic. So if your patient is temperature's dropping, kind of like what you're saying, and you don't need as much anesthesia. So you should be turning down your patient if they're getting colder and colder and colder. So, yeah. They have a higher risk of anesthetic overdose, because as they get cold, if you don't adjust the anesthesia, they can get overly deep. So we don't want to get that overdose level. Now, the other thing is, the colder they are, when you wake them up, they're going to start to shiver more. When they shiver, that's muscle activity, demands oxygen. You can increase an animal's metabolic oxygen requirement the more they shiver. So it's kind of beneficial to keep them warm. So hopefully they don't shiver as long, because the more they shiver, the more oxygen they need. Now, not every patient shivering needs oxygen therapy, but I would be cautious if I had an oxygen problem in a patient, like I was battling oxygen, and then I have a shivering patient, you have to make sure they're oxygenating. That kind of goes together. And then the colder they are, CNS depression and heart malfunction. If you've ever heard of, God forbid, kids falling through an icy pond, like if they're ice skating, and sometimes these people come out of being submerged in cold water and they think they're dead, and they're actually alive. They're able to preserve brain function because metabolic rate drops so low. So it can affect the heart, but I'll give you a quick little indication. One of my worst temperature, I had a little Yorkie getting liver surgery for a shunt, which is a very high risk surgery anyway. It's usually seen in puppies, and unfortunately Yorkie puppies. Now this dog has its abdomen open. They had to take it to radiology. There's a long process. My dog got down to 88 degrees. Now, normal body temp 99 to 102. The dog was 88 degrees. Now, the dog's heart rate got down to 60. A 60 heart rate in a Yorkie puppy is extremely low. Blood pressure was falling. I almost had the dog off of anesthetic. Like, I think I had it on 0.5%. And I gave the dog atropine to speed up the heart rate. It did nothing. I gave a second dose of atropine. I gave a third dose of atropine. It did nothing, because the brain and the body was in like preservation mode. It was in that hypothermia. Now that's extremely cold. I doubt or hope you never have a patient that cold. Once we got the patient warm, the atropine kicked in and the heart rate sped up. But I couldn't believe it. I had my anesthesiologist there. I was like, I'm battling this patient, and he's like, we got to get the temperature up. And I had everything I could, and the dog recovered. But there was some nail biting moments. There was definitely some issues. So what do we do to combat it? Again, you want to try to avoid, the treatment and OR, you can't really turn up the heat. You can try to make your sponges, I have used warm saline. Um, Definitely don't put them on a plain metal table. They should be on a towel. Sometimes what I do for pediatric patients is I'll take my towels and I'll throw them in the dryer. I'll run it on the heat cycle for like 20 minutes. And when I put them on the table, at least they're warm for a little bit. In surgery, you guys, we have heating pads on the both prep room tables. So I'll put a heating pad in the prep room. Obviously the OR has a heating pad, but the prep room, and that's a water circulating blanket. You can use the forced air, which are the bear huggers. Now we usually use the bear huggers during recovery. Some cats don't like the sound, but I try to get them on a bear hugger. You can use warm water bottles. I'll tell you, some clinics, we have like expired fluids. We will inject like food coloring, so we know those fluids aren't for IV fluids. And we can now we can put those in the microwave. I usually put them in like we usually kept them in the incubator, or you could put them in warm water. And what you can do is you can take 2 1-liter bags and lay them up next to your patient. I usually put the towel over them, and they kind of act like not let the patient roll, so they prevent them from like moving. Some people use a V trough. I'll put these like fluid bags and warm them and put the towel over. You can use in exotics, we tend to use heating lamps. You have to be careful that they're not too close. We just avoid, you don't want to use electric, like pillows like a baby. You put pillows up next to a baby, we can use these. I'm just not a fan of electric heating pads. At BCA, we had this thing called a hot dog warmer. They said, go get the hot dog, and it's a different kind of heating pad too. One thing that we had when I was in Anderson that I really liked is we had the manager, she went and got a giant bag of rice, like at Costco or whatever, big bag of rice. And she got a big package of generic tube socks. And we would fill the tube sock like 3/4 with rice and tie a knot. And then you could throw the rice socks in the microwave. Now, I would always massage them to make sure there's, maybe like a minute or two to make sure there's not a hot spot. But the rice socks, and I like to put these on their pads, their paw pads. Oh, baby socks, you can put that on this slide. At school, we have a bin of baby socks, and you can put them over their paws because that's where they lose their heat. A lot of people forget about the paws, but if you can cover the paws with baby socks, some people saran wrap. I think there's a picture in your textbook, or I've seen it somewhere. They have a Chihuahua that's getting ready to have surgery. The whole dog is wrapped in saran wrap, except for the leg they're doing surgery on. And saran wrap, or like that press and seal, they look ridiculous, but it prevents heat loss. And these rice socks were great. We hired a new kennel girl once, and she was very interesting. Didn't have a lot of experience. We hired her. I came out of surgery and I said, hey, could you get me some rice socks for my patient? Because I was recovering the patient. And I'm sitting here waiting and waiting, and I'm thinking like, okay, where are these rice socks? Like, I kind of need them. I go in the kitchen, and she had cooked the rice, and she was trying to, like, she microwaved it or something, and then she was trying to shove cooked rice in the socks. I just kind of put my head down, and I thought, oh dear. I said, no, we don't cook the rice. We use it dry, and we just put it in the sock. And the nice thing was, after surgery, you could undo the sock, dump out the dry rice, wash the socks, and then just reuse them. So we always kept a bin of rice socks, fluid bags, put them on their paws. Those are definitely things to keep them warm. Now, to give you an idea, when you guys are sedating for radiology, they're laying on a cold table, and those patients are vasoconstricted with the drugs. they're on a cold table for like 30, 45 minutes, you're going to see temperatures, especially in the little guys and cats. They're probably going to get down to like maybe 94, 95 degrees. Um, like I said, I'm at Purdue. I'm used to like patients that are almost 90 because our surgeries are so much longer. And Dr. Paul just doesn't even like them really below 96, 97. But it's pretty common. You just want to get them warm. The hard thing for you guys in radiology is you can't put them on a heating pad because you're taking x-rays. You can bring a towel in there and cover them like in between x-rays, keep them covered. um, remove the towel when you go to take the x-ray. So there are like little tips you can do. Now, a different thing, you guys will battle hypothermia. Very rarely do you have hyperthermia during anesthesia. If we see this, sometimes you overdid the heat. I don't feel like I've ever really seen this in a patient. But it could be a reaction to the drugs. Now, if you have a patient that has a pre-op infection, like say they had a septic abdomen or they had like an infected wound, but you should have a pre-op TPR. Were they hyperthermic? Did they have a fever before surgery? What I'm talking about here is the patient was normal pre-op, normal temperature, and then they spiked a temperature during, not they came in with a fever. That's different. Um, but for some reason, they can't get heat. And this can sometimes be seen as they've been on heating during the surgery. You can give cold fluids intravenously. Sometimes in heat stroke, we've passed like a urinary catheter up the rectum, and you can do what's called a cold water enema. If you chill them through the intestinal tract, through the colon, that can sometimes cool them. You can put them on fans. You can use ice. Alcohol is controversial. There's a lot more doctors I've worked with recently, and because alcohol can drop their temp too low. You have to be careful when you lower a temperature, because when they drop, if you keep chilling them, when they hit 99 degrees, they'll drop pretty rapidly. And then you're trying to warm them up. So ice and alcohol can be controversial depending. I work for some doctors. They're like, I don't use alcohol. I don't use ice. Just try to use cool water and bring it down slowly. And fans are good. Now, if you're concerned, if the doctor thinks it's a reaction and you have a reversible drug, probably going to reverse the patient. You can increase your flow of oxygen because that's going to cool them. There is another condition called malignant hyperthermia. Now, this is seen in humans and pigs. So people can get this, tend to be seen in pigs. I did lose a greyhound to this when I was at Purdue. So it's not that it's only people and pigs, occasionally can be seen in dogs. It is a genetic defect. It is a genetic muscle defect. And what happened, it used to be brought out by halothane anesthesia. ISO and SIBO don't tend to bring it out as much. You guys don't use halothane anymore, but in my day, this dog had halothane. That's because I'm old. But it can be caused by restraint, but it was usually brought up by the anesthesia. The patient, they actually feel hot. You can actually feel them. They can get stiffened muscles in their ears and their gums, get that injected red color, and you'll get a spike in carbon dioxide. You can also, they become tachycardic. Now, if this is starting to happen, this is fatal. The best course of action is to stop anesthesia, start giving them 100% oxygen to dilute out the anesthetic as fast as you can. You can try to cool them. There is only one drug that treats it. It is called dantrolene. We didn't even carry it when I was at Purdue because by the time we recognized it, we were spaying the greyhound. It was a rescue greyhound. We were doing a spay. It was going downstairs to get a dental, and it was going to become a blood donor. And at the end of surgery, I'm like, he's got brick red gums. His heart rate was going up. I was trying to bag him. And by the time he got down to the dental, they took his temp and he was like 104, 105 degrees. And then he started having tachyarrhythmias and went into cardiac arrest. So by the time it was, he got down to the dental, um, human hospitals do carry it because people are predisposed. People can be predisposed. And like I said, with the newer anesthetics, it's not as common. But I do want to bring it up. Okay. And if you have any questions, pop in. Now, looking at the depth, I've talked about everything you're monitoring, vital sign wise, mechanical sounds, but now we have to look at what the patient shows as far as reflexes, because that's an indicator of CNS function. Because the majority of these reflexes are autonomic. Like if you touch the eye, they should blink. If you pinch the toe, they pull it back. If you try to open their mouth, they have jaw tone. So that's what I'm talking about. If they're conscious, we expect if we touch their eye, they should blink. So everybody should be familiar with, if you do this test on an awake animal, this is what they do. And obviously, if they're adequately anesthetized, if you guys remember the beginning of this lecture, I talked about the stages and planes. I talked about when do these reflexes change? When do we start to see changes? What we're trying to get to is, obviously stage 3, plane 2 is your surgical anesthesia. Stage 3, plane 3 is when they're almost all absent and then they just get worse. So these are the reflexes that we're going to talk about. Now, the way they usually say, is it present, is it decreased, or is it absent? Now, you guys won't write that. You guys won't record on an anesthetic record those, you won't write decreased or gone or whatever. This is just kind of your assessment that you kind of just keep here that will help you determine your vital signs if you're concerned about your vitals. The swallowing reflex is anytime something is present in the pharynx, which is the throat. You expect them to be able to swallow. Now, during anesthesia, you're not going to be opening their mouth and trying to touch the back of their throat. What you're going to do is you're going to look at their neck, and periodically, if an animal starts to swallow, you see movement in the neck. That's how we're going to assess it during surgery. Now, I will tell you, when you go to intubate an animal, when you give the propofol, someone's going to open the mouth and you're going to try to put the tube over the epiglottis into the larynx and into the trachea. Now, if an animal has a swallow reflex, if you touch the epiglottis, they should close the larynx and they should fight you. And that's how I determine, do I have to give more propofol? Like, I'll give an amount of propofol, and if it's enough, they should lose their swallow reflex and allow me to pass the tube. If they don't, then I haven't given enough. Now, again, the swallow reflex is still a little present in stage 3, plane 1, because remember, that's light anesthesia, but that's when we pass the tube, and you should lose enough swallow. Again, never force. I'm going to be talking about placing ET tubes later. You never want to force it in. You never want to try to push, because you can cause swelling in the larynx. So you don't want to force it. You should just wait for them to open and then pass it in. It's present when they're light, which is stage 3, plane 1. Stage 3, plane 2 is when they lose it. So then it should be gone. And then when you turn the patient off at the end of the procedure, when you start to see the swallow, that's when you know to pull your ET tube. So the number one thing you look for is my patient swallowing, because it is a protective reflex. If they're awake, you want them to be able to swallow in case, if they vomit or aspirate, they have to be able to protect their airway. So I never pull an ET tube until my patient has swallowed 3 times, and that's what we look for. The laryngeal reflex is very close, is kind of laryngeal and swallow go together, because the epiglottis and the vocal cords, which are all part of the larynx, if they're touched, they should close. epiglottis should close, larynx closes, and it prevents aspiration. The only time you're looking at this is during intubation. So once they're intubated, we don't typically assess the laryngeal reflex. You'll just look for swallow reflex. Now, there are animals that have a very sensitive laryngeal reflex, particularly cats and pigs, sometimes calves and goats. But I do want you to know the cats and pigs are prone to what's called laryngospasm. Even during light anesthesia, sometimes cats that are sensitive is like if you touch the epiglottis, sometimes they'll close their larynx, it'll spasm shut, sometimes to the point they won't breathe and they will turn blue. Sometimes I can rub the throat, sometimes I can squeeze their chest and try to force air out. But if anybody has seen in a clinic, normally when we anesthetize a cat, we squirt a little bit of lidocaine, which is a numbing agent. We squirt it in the back of their throat. I drip it on the laryngeal folds, and it helps to numb them so that they're not as sensitive. So, and again, I don't do that in a dog. You don't do that in a horse, but in pigs, small ruminants, and cats especially, is we usually use lidocaine. Now, some clinics have a spray. I usually just draw up injectable lidocaine, a little amount. And when you squirt it back there, it's a tiny amount. You don't have to worry about them like inhaling the liquid. It's not enough to, it's a very tiny amount. So it's not enough to cause aspiration. And cats are sensitive to lidocaine anyway. So we use very, very tiny amounts. I'm not a fan of lidocaine gel, because to actually put on the gel, you actually have to touch the folds and you can induce spasm, but I prefer the drip. And in cattle, they have a spray, like an aerosol spray that you can put back there. One of my favorites that I use 5 million times during one procedure, the palpebral reflex, and you're looking for a blink. So if they're awake, and this is where you tap the medial canthus. I mean, sometimes I tap all around, but really if you tap at the medial canthus, then you should get a blink. Some people say if you stroke the eyelashes, then, there's not a lash reflex. If you're touching the eyelashes or the medial canthus, it's the palpebral, and you're looking for a blink. That's what we're assessing. It should be present when they're first anesthetized, stage 3, plane 1, but it's probably a little diminished. It's probably not brisk. It might be like a half blink. It's like we're losing that reflex. If it starts to be diminished, I know they're falling asleep. Now, horses tend to have a delayed palpebral response, so they're going to use the corneal reflex, which I'll talk about. But you can look here, is all you got to do is tap right here by the canthus and look for a blink. And again, this is one thing I like a lot during the procedure. Now, a pedal reflex is normally if you pinch a toe, bend a toe, pinch the toe web, you expect the animal to withdraw. So some people will call this the withdrawal reflex. It's really a pedal reflex. This is typically in small animal. You're not typically going to pinch a horse hoof or a cow hoof and things like that. So in dogs and cats, this is good. They should have a little withdrawal when they're first anesthetized. And then when they're in surgical anesthesia, this should be gone. Stage 3, because if they can feel you pinch a toe, they're going to feel a surgical blade. And high intensity, sometimes I see people I see students, they just kind of go, they're like, oh, they're not, I'm like, pinch. I take my fingernail and I dig it in their paw pad, or I pinch in between their toe web. Sometimes people twist a nail, they kind of like crank it. It has to be strong. And trust me, I'm not hurting them. You're not going to hurt them. But you want to be sure, because again, they're about to have a blade put to them. So before the doctor comes in, this is one thing. If you want to know, if Dr. Paul and Dr. Ritz, if you're the anesthetist, they're going to look at you and say, is my patient ready? And then I look at you And I go, are they ready? It's up to you to say, yeah, go ahead and cut. So usually when my surgeons are coming in, I like to test this, especially because I know they're going to look at me and go, I'm ready to go. So you can see in this picture here, they're kind of pinching and giving it. Like I said, sometimes I take my fingernail and use, sometimes people will use, usually if a doctor's doing a neuro exam, and some of you may have seen this at a practice, they'll take a hemostat, which is a hemostatic forceps, and they'll pinch the toes with a hemostat. And those doctors will crank. But again, we're testing to see, can they feel that? Now, one that I don't use as often is the corneal reflex, unless I'm really concerned about deeper brain function. If I have a head trauma patient, when I did radiation, one of our common radiations was brain tumor patients. And so if I had a patient with a brain tumor, and I'm really worried about CNS, I'm going to look at the corneal reflex. And it's what you're doing is this is assessing the eyeball within the orbit. And we're looking to see if they'll blink or retract the eyeball, kind of pull the eyeball back. Now, you can use it in horses. They usually just drip some saline onto the eyeball and see if the horse kind of pulls the eye back or blinks. I've also, when we've done this in dogs, especially like head trauma and stuff, we'll take a sterile Q-tip, moistened, don't use dry. We'll put saline on it and use the Q-tip moistened to touch the cornea. So I've seen people do the drops and I've seen people use the moistened. You just have to be careful with the moistened Q-tip. You don't want to cause an abrasion. You know how bad your eye feels if you get a freaking eyelash in your eye? Can you imagine a Q-tip touching your eyeball? It could be pretty painful. So it is present in light and medium, but it's usually used most in large animal. You can see right here, they're dripping the saline on the eye looking for a retraction. The other eye test, and again, I don't use this as often, is a PLR, and that's the pupillary light reflex. And what you're looking for is when you shine the light, do the pupils constrict? And remember, they should be direct and consensual. You shine it in one, the other pupil should do the same thing. Now, in light and medium anesthesia, they do have a PLR, but when they're deep, you lose it, especially if I'm worried about an impending cardiac arrest. If I'm really worried my patient is too deep, an eerie sight is if I look at my patient's eyes and they're dilated. If you've ever heard in CPR, if someone says a patient is fixed and dilated, that means their eye position is fixed, central, and their pupils are dilated. And then you shine a light and the pupil does absolutely nothing. And this is an indicator of brain function. You're shining a light in an eye. I'm not testing the eyeball. Can the brain detect light and create a protective reflex, which is to constrict? That's what you're assessing. And again, I'm also concerned if one constricts and the other one does not, then that means they're not consensual. They're not doing the same thing. That can end up being an indicator of something wrong in the brain, especially like your head trauma, brain tumor patients. We worry, can the brain coordinate a coordinated response? Now, again, when they're anesthetized, I don't expect it to be very brisk. It's going to be somewhat sluggish or delayed in stage 3, plane 1 and 2. And then it usually disappears in stage 3, plane 3, plane 4, and so on. You start to lose it. Now we only have a couple more minutes. The other thing that we tend to look at, is there any spontaneous movement or muscle tone? Now, muscle tone is important. It's not a reflex, okay? But how I assess this is, let me show you, is jaw tone, okay? Will the animal allow me to open their mouth? An awake animal, it's very difficult. And when they're dead, it's super easy. And when they're anesthetized, it's somewhere in the middle. Now, if an animal is adequately anesthetized, they should have loose jaw tone. Puppies tend to be more loose than normal because they don't have a lot of muscle. Geriatric patients can be sometimes tighter because they have TMJ. So sometimes those patients, but as long as you feel it when you anesthetize them in the prep room, like you feel it right away, you'll get an indication of that patient's feel. It's just an eerie feeling. Sometimes you can just feel them and they're just completely limp or flaccid. But jaw tone and just generally feeling their muscle is good. Now, remember I told you eye position is huge, huge. So here's a central eye position. This letter B is where you want to be. When you open the eye, you should see a lot of white, a little bit of the third eyelid, maybe a little bit of the pupil or the pupil there. But this is an eye, it's almost like they're looking at their nose. Now, if I see this eyeball, it could be they're very light, like you just anesthetized them, or they're too deep. That's when you have to look at your jaw tone, pedal, heart rate to see which way you are. And then let me show you this next picture is here's some of the pupil, we got dilated here. Now I'll give you an example. We're gonna talk about the opioids. We do drugs next. We talk about drugs. We don't do drugs. We're gonna talk about drugs. But when we use opioids in cats, it causes pupil dilation. They get those saucer eyes. I call them like saucer eyes. They just look like big saucers. Kind of reminds me of the cat in Shrek, like the big open, So cats sometimes will get, certain drugs can cause pupil dilation. So sometimes, this can be an indicator that they're too deep, but also what drugs did they get? You're looking here, you're starting to see some constriction, and then D, they're extremely pinpoint. Okay, the other thing is that you want to judge as many things as possible. Like I said, if you came to me and you said, Miss Landeros, oh my God, the heart rate is 60, I would go, that doesn't tell me a lot. I mean, it tells me the heart rate's 60. What was it before? What is the respiration? Does the dog have jaw tone? Is there a blink? Or is respiration dropped? Are they pale? What's their blood pressure? So you see, you have to assess multiple pieces to make an assessment. One value by itself is not valuable. And the other thing I want to mention is I use a lot of these values for trends. So let me give you an example. Some people say they don't like blood pressure cuffs in cats because they think they're inaccurate, and they can be. But say you had a mean of like 90, and then you had a mean of 80, and then you have a mean of 70. What is it telling you? It's pretty simple.
Wouldn't it be that the mean is about 80?
Well, or that it's dropping, right? So, I mean, you could potentially average them, but so say, for example, nobody believes that number. They don't believe it's 90, they don't believe it's 80, they don't believe it's 70, but it's dropping. Whatever the number is, do you see that it's dropping? So you can use it. Now I can say the trend is that it's dropping. Or like heart rate. If you like it's 120, then you get 116, then 102, then 96, then 85. Now those numbers are more accurate because you have a stethoscope, but the trend is that it's dropping. So when you look at these values, I'm like, if everything is trending down, either your patient's getting cold or deep. If everything is trending up, respiration's going up, blood pressure's going up, heart rate's going up. Well, either my patient's getting light, they're feeling something, they need more pain control. Do you see what I'm talking about? Now, I'm going to stop here in a second. You guys are going to go over, I'm not doing anesthesia records for this. You guys are going to do this in surgery. But what you're recording is you will get a graph. If you look at this picture, you can see, oh, the dots are going down, and then, oh, all of a sudden the dots are going up. Oh, well, I turned the patient down. You are watching the trends, and that's what the anesthesia record is for. So I'm going to stop there. And do you have any questions?